Okay, we are live. Hello from Turks and Caicos. This is our monthly quiz. I got about a dozen cases for you. First case, this is a young fellow in the 20s, had cough and infection. You can see a cavitary lesion right up below. There's lots of inflammation. Yes, you could think about malignancy, but this looks inflammatory. It ends up this patient did go around a lot in caves, and this ended up being infection. And what do you think it was? Could be TB. It was histoplasmosis. Really nice example. We think about histo usually as a chronic granulomatous disease, not as a cavitary lesion with inflammation and little else, but a great case of histoplasmosis. Patient with chronic cough, dilated esophagus, maybe it's esophageal cancer. We follow it down, really dilated esophagus with transition at the GE junction. Lots of food in the esophagus. I don't see a foreign body. Remember, we've seen several cases where the patient has swallowed some steak and had obstruction distally. You could think about esophageal cancer, gastric cancer, but a dilated esophagus like this, lots of food matter. What do you got to think about? Here's a sagittal, is achalasia. Great example of achalasia. Chest pain, rule out dissection, large mouth, smooth borders, no calcification in the left atrium. It's too big for a thrombus. Atrial myxomas is what you typically think about, but myxomas often have calcification, but not always. You could see it extends right to the groove between the right and left atrium, which is a classic location for an atrial appendage, for atrial myxoma, that is. And this is a large one, a really nice example. Here's the coronal of a atrial myxoma. Really nice case. Rule out dissection. There's a little outpouching you can see off the aorta. Could this be a dissection? When you look at the oblique view, there's a connection between the aorta and the pulmonary artery. What is that? That's not a dissection. It's not a fistula. It's a classic appearance. What is it? It's a patent PDA. Usually it's in an adult, like this is an older patient, it's incidental and asymptomatic. The big thing is not to confuse it with a dissection or a fistula or some other possibility. Another case, hematuria, non-contrast scan. There's a big mass in the bladder with calcification. There aren't that many masses in the bladder that calcify. Here it is a little bit later with contrast. Leiomyoma, but usually they don't calcify and they're pretty rare. We have reported some larger ones. Duplication cyst, it's not a duplication of the bladder. It's not a diverticulum. Calcification. Calcification pushes you always toward neoplasm. Here it is on the MIP imaging. You can see the large mass. And bladder cancer is the answer. And again, I don't see that many bladder cancers, but most of the cancers we see are small. They're relatively vascular compared to the urine in the bladder, but they can be calcified as well. Patient with fever. You're looking at the bladder again. There's a Foley catheter. Still have that cough, and you could see that's air in the bladder wall, better shown on the images with lung window. Air in the bladder wall typically is inflammatory. It's pneumatosis. It's cystitis, and the diagnosis is emphysematous cystitis. Patient also had pyelonephritis. Usually it's a patient who is diabetic. This patient also had Cushing's disease. These are usually sicker patients, often from nursing homes, and they're not very well managed. Another patient, abdominal pain. There's a lesion, a really small lesion, about a centimeter, in the head of the pancreas with enhancement. And believe it or not, this actually measured a bit of fat. I don't know what that means, but here it is again. You can see it on the axials and coronal. Vascular lesion. Doesn't look like an IPMN. You don't get rim enhancement like that. It's small, as I said a centimeter, but it was actually 13 millimeters. What could this be? Vascular lesion, small? If the whole thing enhanced, you wouldn't think twice, and you would simply say that this was a neuroendocrine tumor. And in fact, this ended up being a neuroendocrine tumor. What was unusual was the fact centrally there was nothing special to explain this on the patient's pathology. Left upper quadrant pain, large mass, which is arising from the pancreas, has coarse calcification. You could think about an MCN, they can have calcification, but they're more cystic. You could think about a serous cystadenoma. They can have rim calcification, but that would be uncommon. And the soft tissue density of this, you're really talking about a cystic and solid lesion with calcification. And if I tell you cystic and solid lesion, you're going to say SPEN tumor. And this was a SPEN tumor. Although most SPEN tumors are females, 9-to-1 over male, and they're in their teens and 20s, we've seen them in males in their 80s, so you never know. Another case, cystic lesion, head of pancreas. You could say SPEN again. You could say serous cystadenoma. You could say MCN. It's not a cancer. It's not a neuroendocrine tumor. Well-defined. MCN would be good location, particularly if it was a 40-ish-year-old female, but this was a SPEN in a 33-year-old female. So again, SPEN has a range of appearances. It's a great mimicker. It's something you always need to consider, though the truth is we don't see all that many of them. Another patient, mass in the pancreas body, cystic, dilated pancreatic duct with glandular atrophy, but it's cystic, so you got to say, well, MCN, that can cause duct obstruction, but it's almost like too many septations, particularly when you look closer at the lesion on the coronal view. When you see a cystic lesion like this with so many tiny cystic components, you got to be thinking about a serous cystadenoma. And you can see the cystic components are better seen on the cinematic rendering, and just a really nice diagnosis of a serous cystadenoma, which is always a benign lesion, though often resected because they can continue to grow. Pelvic mass, bilateral ovarian tumors, but there also is tumor in the pelvis, so you can say ovarian cancer with carcinomatosis. I show you some other images, and you can see clips by the head of the pancreas, lots of collateral vessels. So this patient actually had a Whipple's procedure. And what you're looking at is a patient with pancreatic cancer who now has ovarian masses. This was pancreatic cancer metastatic to the ovaries. And we think about Krukenberg tumors from stomach. We think about them from appendix. But you also need to think about the pancreas. Okay, this may be the last case. Patient was Cologuard positive. Cologuard is used in place of colonoscopy, and when it's positive, that means there's a high suspicion there's a colon cancer, and you could see the patient had a virtual colonoscopy now. Here's a mass, a large mass, maybe 6 centimeters, in the region near the splenic flexure. You can see it here. And here again, it's a pretty long tumor. You can see it's an apple core lesion when you do the virtual colonoscopy with 3D reconstructions. There it is with an endoluminal view. You can see the infiltrating mass and the narrow lumen. So this was a adenocarcinoma of the colon. Unfortunately, it was a large tumor, but this was eventually resected. The good news, the patient had no Mets at time of diagnosis. So that's about a dozen cases. I hope you got them right. I hope you learned something. And I hope you learned that even on vacation, we will come and find you on CTisus, even if it's at 9 o'clock Eastern time, which is a little bit late for some people, it's a little bit early for other people, and there's no perfect time. But there is always going to be great cases. So with that, have a great day, everybody, or a great night.